It is now 11 o'clock, so we will get started. Thank you all for joining the Georgia Department of Public Health Strike and Support Team Office Hour. My name is Maya Labat, your host for today's event, and I will pass it off to Melody Brown from Alliant.
Thank you, Maya. And again, good morning to everyone, and thank you for joining us as we bring you another WebEx or offering from the Georgia Department of Public Health Strike and Support Team Office Hours. Next slide, please. Our presenters today will be Dr. Raven Speltz of the Georgia Department of Public Health. She is supported today by Teresa Fox and Regina Howard, also of the Georgia Department of Public Health. Next slide. We want to thank our partners, not only the Georgia Department of Public Health, but the University of Georgia as well, for without them, we would not be able to bring these presentations and office hours to you once a month. The purpose of these sessions are monthly webinars to bring you updates and any relevant materials that we can bring to you, along with resources for assisted living facilities and personal care homes of greater than 25 beds. This is an opportunity for you to come and share, learn, vent. We also, by all means, if you have questions, please drop those into the chat. If you have a best practice, we really want to hear about that as well. So drop that in the chat. And at any time during this presentation that you feel that you have questions about anything that is being presented, by all means, please drop your questions in chat and we'll stop the speaker to get those questions answered. Each month, we're going to be providing these updates along with tools and resources that you can use and take back to your facilities. And we also have subject matter experts on the call today. Myself, Teresa, Regina, we have Amy Ward and Donald Chitanda, our infection preventionist. So we have plenty of folks to give you some answers to your questions, but also give you some assistance as we go forward. In addition to these office hours, we are also going to be doing a training just as we did in May. That will be in October. So we hope to soon have those dates. And that training will be around general infection prevention as well as respiratory care. But please mark your calendars for the 4th Friday in August. We're going to be talking about cleaning and disinfection of shared medical equipment. So as you think about that, please bring to the table not only yourselves that is on the call today, but think about bringing your environmental services folks or whomever is responsible for cleaning and disinfecting of your medical equipment. Next slide, please. Your opinion does matter. Again, any questions you have or thoughts, or if we need to stop a speaker to answer something, please let us know by entering the information in chat. A link to today's slides will be over in the chat box. Those are all posted on our website along with the recording and the presentation. Next slide. At this time, I'm going to turn the presentation over to Dr. Raven Speltz. Raven, the floor is yours.
Thank you, Melody. I'm excited to be with all of you today. I am a board-certified infectious disease pharmacist, and I've worked in the long-term care setting. So I know what all of you are going through and common infections in this population. Next slide. Here are some objectives today. We're going to be talking about prevention and control. We're going to be talking about antibiotic stewardship and the importance of antibiotic stewardship in preventing C. diff. Next slide. Throughout the presentation, I'll be referring to Clostridium difficile as C. diff, as we commonly do, and on the slide, CDI is C. diff infection. Next slide. Here are the symptoms from CDC on C. diff. Now, most of the time, it's going to be severe diarrhea. Sometimes with C. diff in severe cases, people can have 30 to 50 stools a day. It's a really terrible disease. People can die from dehydration. And sometimes they do have fever. Of course, stomach pain or tenderness. They don't feel like eating. And nausea. So pay attention to these type of symptoms in your residents. Next slide. Let's talk a little bit about the epidemiology. C. diff is a bacterial disease, and it causes almost 500,000 infections in the U.S. per year. More than 80% of C. diff deaths occur in people 65 and older. Of course, those are our residents, right? And the risk factors for infection are recent antibiotic use in the last 90 days. And I will say it can be any antibiotic. Some antibiotics have more risk than others. However, even one dose of antibiotic, even one dose of amoxicillin for a dental procedure can cause C. diff and has caused people to die. Age, of course, age greater than 65 or older is a risk factor. Being in the hospital, being in the nursing home, weakened immune system like HIV, cancer, and so forth, or previous infection. As you will find, a lot of the time, if somebody has one C. diff episode, they're going to have two, they're going to have three. And some of these people end up having to get a fecal transplant, which you've probably heard of in the news or so forth. Next slide. Here are some risk factors for colonization. Now, I will point out that colonization is different from infection. Infection means the person has 3 or more loose stools per day. The person's having diarrhea. They're having these symptoms. Colonization means this person has C. diff bacteria in their stool, but it's not causing an infection. If it's not causing any symptoms, we're not going to treat it. And look at this slide, probably think of your residents. People own antibiotics a lot of the time. Fecal incontinence. Duration is very important. We'll talk about that later. Shorter duration is better. You know, in the past, maybe we treated pneumonia 14 days. Now there's evidence to treat it 5 days in the community setting. Renal insufficiency, people on chemo, people in the hospital, H2 blocker use is a risk factor, famotidine, like Pepcid, also people on omeprazole, Nexium, proton pump inhibitors, that has shown a link as well. Next slide. And this graphic from the CDC shows that up to 70% of nursing home residents receive 1 or more courses of antibiotics in a year. That's a lot of our residents. And a lot of these times, the antibiotic is really not even necessary. Next slide. This slide from the CDC shows increases in antibiotic use during the COVID epidemic or pandemic. And as you will see, there were some peaks in ceftriaxone or Rocephin use. And this is nursing home data. And then in the blue, you really see some peaks, 150% increase, 82% increase in azithromycin or Z-Pats during the pandemic, because initially researchers thought azithromycin had some evidence for COVID that really has been debunked. The Infectious Disease Society of America, the NIH, do not recommend a Z-Pak or any other antibiotic for COVID because COVID is a viral infection. Next slide. Now we'll talk a little bit about the diagnosis. Next slide. Who should be tested for C. diff? Now, I will say that I know in skilled nursing facilities and hospitals, the nurses probably have protocols to test for C. diff. In alternative care homes, assisted living facilities, you probably don't have a protocol, but as a CNA, you can be aware of who should be tested. When should I call the doctor? This would be a resident with at least 3 unformed stools in 24 hours. And that would be type 6 or 7 on the Bristol stool chart. So it's very important to document the texture, the color of the stool on every bowel movement, so other nurses can know as well. Do not test based solely on color or smell of the stool. Now, I'm not a nurse, I'm a pharmacist, but my nurse friends have told me that C. diff does have a particular smell. However, you do not want to test the resident if they are not having diarrhea. Don't just test based on the smell. It has to be 3 or more loose stools in 24 hours. Next slide. You should be able to tell the doctor, is your patient on any laxatives? We know a lot of elderly people have problems going to the bathroom, so they are on Docusade and Senna and Bisacodyl or Dulcolax suppositories. We really want to stop those laxatives for 24 to 48 hours and see if the diarrhea clears up before we just jump to testing for C. diff. Be able to tell the doctor, has the patient been on antibiotics in the last 90 days? That will help him. Are they on a proton pump inhibitor for GERD, for acid reflux? That is a risk factor for C. diff. Recent medication changes. Metformin comes to mind for diabetes. That can cause severe diarrhea in people starting that drug. Recent dietary changes, and has the resident had C. diff in the past? That would also be an important part of the medical history. Next. Here are some instructions on collecting a stool sample. The CDC website has TAP resources, some really good protocols for C. diff, some good information, and the state of Minnesota provides a guideline. There's a link at the bottom of the slide. You want to obtain your sample in a clean, watertight container, stored in the refrigerator until it can be sent to the doctor's office. And you don't want to retest if a test was already done the last 7 days. That's not going to help your resident, and that's not going to have a better result. So we would never test if we've already tested in the last week. And do not test to see if the patient is cured. So let's pretend our resident does have C. diff. They are treated appropriately with a medication for 10 days. You do not retest to see if they're cured. You know they're cured because the diarrhea subsides. Next slide. And we'll talk briefly about the treatment next. Here are some basics. We don't want to use antidiarrheal medications for people with C. diff. And the reason for that is if somebody has this toxin in their intestine, they need to go to the bathroom. They need to get it out. And examples of antidiarrheals would be Imodium, Lomotil. So do not put that on somebody that has confirmed C. diff. You want to be able to tell the doctor, is this the first episode? Have they had C. diff in the past? If they did have C. diff in the past, what treatment did the resident receive? If they used, say, oral vancomycin the first time, you want to try Difficid. There's a new medication the second time. The IDSA and SHEA guidelines from 2017 said that oral metronidazole, y'all probably know it as brand name Flagyl, is no longer recommended. There is resistance to this medication, and it just doesn't work as well. And also, there's a higher mortality with it compared to using the vancomycin or the Difficid. So we really just don't want to use that medication for C. diff anymore. And then the 2021 guidelines recommended fidaxomicin, which you probably know is brand name Difficid, if available, is recommended over vancomycin because fidaxomicin had a lower risk of recurrent C. diff. However, it is quite expensive. Vancomycin orally is still a fine alternative if needed for C. diff. Next slide. And as we were talking about, 1 in 6 patients who get C. diff the first time will have it again in the next 2 to 8 weeks. So it's really important to try to prevent C. diff from the get-go. Next slide. Vancomycin is commercially available in a capsule or as an oral solution. However, some insurance companies won't pay for that. It's quite expensive. Sometimes you will have to contact your local pharmacy to compound a recipe for vancomycin liquid. And administration is oral or rectal. We try to do oral if the patient can tolerate oral, but it can be given as an enema. Here's some side effects there, and you just want to watch out if the patient has muscle pain, cramps, an irregular heart rate, and of course they will have nausea, diarrhea, that is a side effect of the medication, and possibly a headache. Next slide. This is fidaxomicin or Difficid. It is available as a tablet, as an oral suspension. Here's some side effects as well. And a precaution would be a macrolide allergy. So if a patient's allergic to, say, azithromycin or erythromycin, you would use caution because fidaxomicin is in the same antibiotic class. Next slide. And I will hand this over to Teresa and Regina for prevention and control.
Good morning, everyone. My name is Regina Howard, and I am one of the infection preventionists with the Georgia Department of Public Health. And I'm going to talk to you about infection control prevention relative to C. diff. Now, colonization and infection, there's a difference between the two. Colonization with C. diff is more common than infection. Your colonized residents do not exhibit any symptoms of C. diff, which would be diarrhea. Residents with infection will exhibit clinical symptoms of diarrhea and test positive for the C. diff organism and the toxin production. Next slide, please. C. difficile prevention efforts. These residents are very vulnerable to C. diff. So it's very important you know your residents' medical history. It's important that you know whether or not they're on medication like laxatives or antibiotics or paracelsus medication, as was mentioned by Rabin. You want to reduce exposure. Residents are a major source of transmission, and your infection control practice would include reducing the risk of transmission from symptomatic or asymptomatic residents. So it's very important that you constantly educate and demonstrate for your residents hand hygiene, specifically with soap and water. Soap and water because your hand sanitizer is ineffective against C. diff. So that's why we emphasize soap and water. And if you have a resident who has C. diff, they would be on isolation. If you had semi-private rooms, you would isolate your residents with another resident with C. diff. If you have a room situation problem there, room shortage. Also, environmental cleaning. I want to talk briefly about. Environmental cleaning and disinfectant is very important with C. diff. Specifically, you must utilize in this situation EPA-approved List K sporicidal cleaners and disinfection. Again, I want to emphasize cleaning and disinfectants in these rooms because your C. diff organism can live on inanimate or surfaces for at least 5 months. And that's quite a long time. So if you have a vacant room and you're receiving an admission in there and the prior resident had C. diff, make sure those surfaces are cleaned properly. So you would really need in this situation to audit the cleaning effectiveness of your post-discharge C. diff room. Very important. And again, I emphasize that organism can live on inanimate objects for 5 months. Next slide, please. So your pillars of C. diff prevention and control. Again, hand hygiene, soap and water, extremely important. These residents are placed on contact enteric precautions. And again, emphasis is on cleaning and disinfection of that room. Antimicrobial stewardship comes into play as well, which Raven will talk a little more about as we go on. Next slide, please. Again, I cannot emphasize hand hygiene enough. Before contact with the resident, after removing gloves. Some people think because they wear gloves, they don't have to wash their hands. Yes, you do. In every situation, when you take your gloves off, please perform hand hygiene. Also, after contact with that environment of a resident that has C. diff, because that organism is in that space, in the environment. So for enhanced measures, again, do not utilize alcohol hand rubs with your C. diff resident. Use soap and water because you're washing away the spores, which is the most optimal way to perform hand hygiene to prevent the transmission of this organism. And it's also important that you audit your staff adherence to hand hygiene. Next slide, please. This resident, again, is placed on standard and enteric contact precautions. You place your resident in a single resident room with a dedicated toilet. If single resident rooms are not available, room residents with confirmed CDI together. So because we are talking about personal care homes and assisted living, I'm under the impression that the majority of the time, these people are provided their own rooms and usually are not in together. But should you have two who are in together, you can only place this C. diff person in a room with another C. diff person, if that's your situation in your facility. Also isolate and initiate enteric contact precautions for suspected or confirmed CDI. And this is the sign that you would use in that situation because anyone who enters that room, you would want them to know exactly what to do upon entrance. So they would be performing hand hygiene, again, using soap and water when leaving the room. Upon entry to the room, you can use hand sanitizer, but when you leave that room, you must utilize soap and water. So also maintain supplies outside the room that will be needed, gowns, gloves, cleaning wipes, so on. Again, signage should be on the entry door and use dedicated or disposable equipment. Shared equipment must be thoroughly cleaned prior to reuse. And for obvious reasons, no rectal thermometers. Next slide, please. Environmental cleaning and
Regina, can I add one thing? When you're talking about soap and water, just remember that we're not to use bar soaps. It should be liquid soaps containers that you should have. And we should not be using cloth towels. We should be using paper towels because you do not want to contaminate from one person to the other. Thank you.
Thanks, Teresa. That's a very good point. Thank you. So environmental cleaning and disinfection, increase the frequency of cleaning and disinfecting, particularly for high-touch areas such as your doorknobs, your handrails. Again, audit adherence of cleaning and disinfectant to the facility's environmental cleaning and disinfection policies. So it's very important that you educate your housekeeping staff regarding cleaning and disinfection. Talk to them about how long that organism is in the environment. 5 months, that's a long time. And if that room is not cleaned properly, your next admission into that room could be at risk. So please bear that in mind. Use single-use disposable equipment or dedicate equipment to one resident. Here, this is the site, the web link you will go on to make sure that you're utilizing List K specific for C. diff. Your ordinary cleaners, your quats, and your daily disinfectants are not effective against C. diff. And during outbreaks, consider the use of the sporicidal agent for all routine disinfection. Follow manufacturer's instructions for use, and again, educate your staff on cleaning and disinfecting specific for C. diff. So audit the cleaning and disinfection of those rooms. There are many products available where you can do that. There are fluorescent lights and fluorescent markers that you can mark that room prior to cleaning. And once the room is clean, you go back and check to see if those fluorescent markings have been cleaned away. If they're still there, then that room has not been effectively cleaned. So you would approach that person individually, again, have a conversation, educate, and again, emphasize the significance of cleaning those C. diff rooms properly. Next slide, please. As far as environmental services, education, make sure that they're aware there's a particular way in which you should be cleaning. So you should clean from top to bottom. You should clean from the least soiled area to the most soiled area. If there are privacy curtains in that room, those curtains should be changed as indicated when soiled. Definitely replace when the patient or resident is discharged from that area. Those curtains must be replaced. Also, it's important that they adhere to the contact time of the cleaner and disinfectant. So again, educate your staff regarding contact time or kill time for your disinfectants. Your cleaning should start, again, I said from clean to dirty. It should be clockwise or counterclockwise as far as your cleaning. So it's very important that you educate your staff and make sure they are aware and know these principles. Next slide, please. By all means, when you're transferring a resident with C. diff, use the infection control transfer form. If you don't have one, cdc.gov has one that you can utilize and inform the receiving facility of the C. diff history of this resident. Next slide, please. Thank you very much.
All right, now we will talk about some basics for antibiotic stewardship. Next. For antibiotic stewardship, that means we're going to use the antibiotic wisely if needed. But if antibiotics are not needed, we do not want to use them because antibiotics are associated with C. diff, resistance, antibiotic resistance, and of course, antibiotics have side effects. We want to advise the resident not to take antibiotics saved at home. You should never save an antibiotic for leftover because different antibiotics treat different types of bacteria and one antibiotic for one infection might not work for another infection. We also want to inform our residents that they should not take any antibiotics unless they're prescribed by the doctor. And if the doctor writes the medication for 5 days, it should be taken for 5 days. Also document the reason the resident is on the antibiotic. We should never have a situation where a patient's taking an antibiotic, it's on their profile, but no one knows why the patient's on the antibiotic. So it really should be documented somewhere in the medical record or on the MAR, medication administration record. The patient's on azithromycin for community-acquired pneumonia. It should be documented so everybody knows. And ideally, there should be stop dates. Always put a stop date on your antibiotic for 5 days, for 7 days, for whatever the doctor wrote it for. We never want to have a situation where the patient's on antibiotic for 3 months and we don't even know when it's supposed to end. Communicate with other nurses that the resident is on the antibiotic. Then the other nurse at shift change will know, okay, this patient has an infection. They might have some diarrhea as a cause of the antibiotic. And I will say, of course, if you've taken an antibiotic yourself, you probably know it can cause some diarrhea. And that doesn't necessarily mean it's C. diff. Sometimes it's hard to tell the difference. But of course, we can test the resident if there are 3 or more loose stools in the 24-hour period. Just because somebody has diarrhea taking an antibiotic doesn't mean they necessarily have C. diff. We have to do the test. Next slide. This is a campaign by the CDC, U.S. Antibiotic Awareness Week. Now, of course, we should use antibiotics wisely every single day, but there is a particular week in November when the CDC has this campaign. There are a lot of great resources on the CDC website, brochures, handouts for your residents, their families, for the staff. You can put it on your Facebook website so the residents' families know, hey, we're a part of this. We are using antibiotics wisely because we want to keep your residents safe and we want to prevent C. diff. Next slide. This is a good poster, for example, from CDC, and you could put this up on the bulletin boards at your facility. The common cold, do you need an antibiotic? For most colds, they are viral infections. They're self-limiting. The person might be sneezing, might have a mild cough, not feel well. But if the resident asks for an antibiotic, you could say you probably just have, of course, document in the medical record, but if the symptoms seem mild, it is probably just a cold and an antibiotic is not needed. If the person has a headache, you could give them some ibuprofen or Tylenol. If the person is, congested, they could take a Flonase inhaler. Those are over-the-counter symptoms. Next slide. This is a good graphic about how antibiotic resistance happens, and you could distribute this at your facility. It just shows that when a person's taking an antibiotic, it destroys the bad bacteria causing the infection, but also the good bacteria. Of course, we have good bacteria in our gut and our skin, keeping things at balance. But when you take an antibiotic, you do throw your normal antibiotic flora into a change, and these the good bacteria are killed, and then these bacteria that are resistant can flourish. This is a good graphic here, and it explains it quite well. Next slide. This is a graphic CDC released recently. Antibiotics do not work for COVID. As we talked about, we don't want to give Rocephin or azithromycin or doxycycline or any antibiotic for COVID because there are antivirals that have proven to be effective for COVID. And also, there's a report that the CDC released actually recently that shows that during the pandemic, there has been an increase in antibiotic-resistant bacteria, some very harmful bacteria that causes infection that are hard to treat over the course of the pandemic. And there could be several reasons for that. Over the course of the pandemic, the antibiotic stewardship programs were not as strong in hospitals. There were antibiotics given for COVID that really didn't need to be given. So we just want to reverse this trend and use antibiotics wisely. Next. Here is a poster by AHRQ. They do have some good resources. This is 4 moments of antibiotic decision making. You could give these posters to residents and families. And of course, a lot of the time the families will say, well, mom's not acting right. She seems confused. She probably has a urinary tract infection. Can the doctor write an antibiotic? That sort of scenario. But we really want to show our families that antibiotics should be used correctly, and just because somebody's confused does not mean they have an infection. You need to do some more investigation. Maybe the resident's confused because she's on a new medication. Maybe she didn't get enough sleep last night. Maybe she needs more stimulation during the day, and so forth, before just jumping to the conclusion that a patient has an infection, like a urinary tract infection. We want the family to know there are side effects of antibiotics, so we want to use them judiciously. Next. That is the end of our presentation. Here's a list of our team contacts. Feel free to contact any of us with questions, and we have enjoyed delivering this information to you. I will hand it back to Melody.
Well, thank you, Dr. Speltz and Regina today. And Teresa, you had also made a comment in there. So again, as Dr. Speltz said, this is a list of all of the contacts for the Georgia Department of Public Health, the HAI team contacts, along with their email addresses and phone numbers. I have dropped into the chat link over the link for our website where you can find these slides. Dr. Speltz has given several opportunities for you to be able to go in and download, as did Regina. You can download some of the posters, but also some of the educational materials as well to work with your families and also your residents. We realize today that you all are either assisted living facilities or personal care homes, and it might have seemed that some of this information was for nursing homes only, but we really feel that it was very important to bring this information to you so that you were able to really grasp on to what hospitals and nursing homes are using, but also apply it to your settings. Because during the pandemic, as Dr. Speltz said, we know that antibiotics were given, and especially, I think you said, Dr. Speltz, azithromycin and a couple of others, or the Z-Pak. So if that happened and your resident did have diarrhea, there's a possibility that C. diff might have been lost or not found, and it didn't get really bad. So we're not sure what all we will learn as more data comes out of the pandemic, but we want to make sure that you are all aware. In addition to that, next month in August, we're going to start or have a more in-depth conversation around cleaning and disinfecting, as I said at the very beginning. Regina, you had a very good slide for everyone to view as far as environmental services. So we ask that you take that slide and that graphic and share, especially, high to low. And Regina, you might want to say it a little bit better than I can say it, but high to low, less to more, more to less, and everything. So in that
Clockwise
case,
and counterclockwise.
okay, clockwise and counterclockwise. So, that's a very good slide. A lot of times, environmental services folks are not included in a lot of the trainings and everything. And we know now that after the pandemic, and the pandemic's not over, we're still having positive COVID cases, but we know now that they are very integral to all of the training that's going on in your facilities. At this time, I'm going to ask if you have any questions, please enter them into the chat box. And in addition to that, a survey is going to pop in just a second or two. And we ask that you complete that survey and give us information as assisted living facilities and personal care homes. What do you want to hear about in the future for future offerings? We do already have the cleaning and disinfecting plan for August, but we are very open and we want your feedback, and we want to know what will be beneficial from an infection prevention standpoint for us to bring you tools, resources, and presentations that you can use for your staff education as well as your family education. So that poll is going to be open for about a few more seconds, or about a minute, I think. And during this time, just please let us know what your feelings are. And if you have questions, we'll ask that you enter those into the chat box as well when the poll pops down. Dr. Speltz, any additional parting thoughts that you have today? You've given us a lot of advice, a lot of thoughts, but for this particular assisted living and personal care homes, anything that you forgot to say that you would like to say at this moment?
Well, I would just like to say that for long-term care facilities and for hospitals, CMS does require antibiotic stewardship programs. Now, at non-skilled facilities, like assisted livings, that is not a requirement. However, if y'all just wanted to go above and beyond, I think it would be great to start an antibiotic stewardship program at your facility. It can be very basic at first, but have leadership on board. Have your CEO or your manager publicly say they support antibiotic stewardship, write up a little policy, and have somebody tracking antibiotic usage at your facility. That could be part of a nurse's job, to track how many antibiotics are being used per month, how many C. diff cases are occurring per month, and that would really help your residents and be able to quantify what's going on at your facility. And like I said, we have CDC is a great resource. Alliant has some great posters on their website, and if you go to the Georgia DPH, Healthcare Associated Infections, we have some resources for long-term care facilities on our website, which still could be applicable to your facilities as well.
Well, thank you, Dr. Speltz. And just if any of you would like to even explore doing that, we'll be more than glad to assist you. Just reach out to any of us that are on the call today from either DPH or Alliant, and we'll help you get started. As Dr. Speltz said, this can be very simple, an easy process to get started, and have some tracking mechanism just to kind of know what's in your buildings. Next slide, please, Maya. I don't see that any of you have entered any.
Melody,
Yes.
I'd like to emphasize this would be when she was talking about antibiotic stewardship.
Yes.
Most activities, you have activities and you have family councils and you have resident council meetings. If you could invite someone from your community to come and talk about antibiotic stewardship relating to your specific community, and that's a great time to pass out information, especially the chart about antibiotics resistance develops. That would be a massive first step in educating not only your residents, but your community residents. I've found in the past that it's been very successful when it's done at the community level.
Well, thank you, Teresa. And do you have any recommendations of just thought processes of who to invite to start those conversations?
I, in the past, worked antibiotic stewardship in another state. And what we did is that we would get in touch with the infection preventionist at our local hospital, and we would ask them to come and talk to the long-term cares, or the patient resident councils is who we were asking them to talk to, and talk about what is the resistant in their community, what do they actually see, and how the community could be of assistance. We had some physicians that were really active in antibiotic stewardship. That's always a good resource for that. Or a local pharmacist. Don't forget that as an expertise in your community of could talk about antibiotic stewardship. But if you're interested, as Mel was saying, you can reach out to any of us and we'll see if we can get you in touch with a person that might be willing to come and speak to your residents about antibiotic stewardship.
All right. Well, thanks, Teresa. And you're exactly right. The local hospital infection preventionist, as well as the local pharmacies. So whatever you need or to get started, if that's an avenue that you want to go down, we are more than willing to try to help you start that process and follow along with you as well to provide assistance as we can. As I've said a couple of times, please save the date on August the 26th. We're always going to be doing these calls on the fourth Friday. We may have to make a change or two when we get down to holiday season toward the end of the year, but right now we're scheduled out for the fourth Friday at 11 a.m. So mark your calendars, and then you will be getting an invitation where you can register once a month from Alliant. Next slide, please. Again, we want to thank the Georgia Department of Public Health, Dr. Speltz, Regina, Teresa, for all of your help today in bringing this program to the assisted living facilities and personal care homes that joined us, and also the University of Georgia. And we'll speak more to that about a package that's coming. We're going to be talking about that next month. So join in with us during that time. Last but not least, we ask that you join us at Alliant Health Solution on our social media platforms, where we're putting out information almost daily, if not weekly, by all means, on Facebook, Twitter, LinkedIn, and YouTube. We have several YouTube videos for reference that you can go out and use for your staff education, as well as some your family and resident education too. So again, the link for today's slides are in the chat box. We'll be putting a recording to this presentation there in about 48 hours working days, so that you can pull that down and listen to it or share with your other organizations. And so I'm going to put out a call to action today. If you have folks in your organization, if you're part of a corporation and others are not on the phone with you or joining in today, please send them an invite, or please forward the invite to them and get them to join as well. So next month, again, we're going to talk about cleaning and disinfecting of medical equipment, and we hope you all can join us. But today we will conclude, and thanks again for taking time out of your busy schedule to be with us. Thank you very much.